let's change gears towards something pretty sciencey, medicine-y. So yeah, we're going to talk about cardioversion. I wanted to give special thanks to Dr. Smith, Dr. Willis, and Dr. D'Souza. For the purpose of this talk, I'm mostly going to be using the word atrial fib. A lot of studies just can't reach the power to just do a Flutter study because you just don't get enough Flutter patients, so they lump them together in the AFib studies. It's a standard understanding that you could kind of treat AFib and Flutter pretty much the same. So a lot of this, I'll be referring to atrial fib, but I'll be using it interchangeably with Flutter. These are our learning objectives for today. Let's break it down. So first, do no harm. So we're going to look for how to evaluate for secondary causes of AFib and also assessing for stroke risk. Next, we are going to learn about cardioversion, two different types, chemical and electrical cardioversion. And then we're going to get into the rate and rhythm control controversy, understanding both sides and what is done outside the US. And then I wanted to talk about the autoaggressive protocol, which I think is pretty cool and maybe spark some interest in getting it done maybe over here sometime. All right. Let's begin. So let's begin with a case. So we have a 58-year-old. He has no medical problems. He said that right before he came to the hospital, he drank a Red Bull and then started feeling palpitations, feeling his heart racing. He denies any chest pain, shortness of breath. He was otherwise healthy, no fevers, vomiting, nothing like that. No surgical histories, not on any meds, no allergies, everything negative. So you look at his vitals, you see he's pretty remarkably tachycardic. His blood pressure is a little bit elevated. The rest of his vitals is pretty much okay. You do a physical exam, everything's pretty much normal. I mean, you listen to his heart, it's racing obviously, but no murmurs, lungs clear, belly soft, no signs of infection. So what do you want? Let's get the EKG. I'll give you guys a second to look at it and maybe someone can tell me what they see. What do you guys think? It's pretty cool EKG, right? Okay, so someone mentioned they see QRS alternans. Good. What else? No distinct P waves, correct. I also saw vague ST elevations, ST depressions. Yeah, the question is, this is a very fast tachycardia. Do you see any P waves? Could this be sinus or not? Anyone suggest maybe some other waves that they see here? Yeah, I'm like, is there flutter waves? I feel like I could maybe draw out some flutter waves at 300 milliseconds here. So I actually kind of think it's flutter. What would give you a flutter of 200 beats per minute? What kind of block? This is actually a 2 to 3. So 2 QRSs go through for every 3 flutter waves would give you a 200. So the providers who had this patient weren't really sure because it was a very fast tachycardia. They tried vagal maneuvers to see maybe it was an SVT. And when that didn't work, they gave adenosine. And none of that really worked to ablate the rhythm. So they give diltiazem, and it brought the patient's EKG to this. Heart rate 120. And this is atrial flutter with variable conduction. All right, so let's do a quick poll of the audience. What would you guys do for this patient? I put a couple different options up here. Admit, start anticoag, discharge. So let's just take it to a vote. Who would admit the patient for rate control? Raise your hand. Nobody. All right, discharge with follow-up. Nobody's doing that. Give antiarrhythmic. 3 people. Start anticoagulation. Nobody. And immediate electrical cardio. Are you serious? You guys would do that today? Even before my lecture? I doubt you guys would, but maybe after this lecture we could consider doing that. Okay.
I would have done it before your first lecture.
All right. Let's start our first learning objective. we're going to be talking about recognizing the difference between primary and secondary AFib. So I want to begin with this very interesting paper. I really recommend you guys to read this paper. It's a great paper, and a lot of times during shift, when I'm working with residents, I recommend them to read this paper when we have a patient like this. So it was retrospective. It was about 600 patients, and they were looking at providers who treated atrial fib, and there was two different kind of treatment styles that they used. The first one was the providers just focus on treating the underlying condition, and the second one was giving some sort of rate or rhythm control agent. These were the outcomes that they were looking for. The first one was safety, and the second one was adverse events and success rates. So let's look at this study's results. They noticed that for the providers who chose to give rate and rhythm control, there was a 6-fold increase in adverse events compared to that of the providers who chose to treat the underlying, and a 12-fold increase in major adverse events. So if a patient comes in and something's causing their atrial flutter, they have like CHF or something, if you give them metoprolol, increased risk for adverse events than if you just treated their CHF. Let's look at another thing. Here they just looked under rate control, first for success. At hour 1, there was a 16%, but it got higher, the success rate, by hour 4. And conversely, the adverse events decreased by hour 4. So again, if someone comes in and they're sick and they're also in rapid atrial fib at a rate of 180, if within the first hour you order them metoprolol or diltiazem, you have lower success rates and higher adverse events. Then if you just focus your resuscitation, give them whatever they need, fluids, antibiotics, whatnot, and then by hour 4, you consider giving them rate control, you'll have better luck. Another thing this paper kind of talked about is they hypothesized a lot of these atrial fib flutter patients were a little bit hypovolemic, a little bit dehydrated. So they looked at people who, so if you focus on treating the underlying and you gave them fluids, by hour 4, they saw a reduction in heart rate by 44%. So if they came in at like heart rate 180 and all you did was give them antibiotics, antipyretics, and fluids, their heart rate would be 100 by the time you admit them, without giving them a cope or dilt or anything like that. However, if they came in and you started freaking out focusing on the heart rate, you didn't give them fluids, and you just gave them diltiazem or metope, the success rate is a lot less than 20% reduction in heart rate. So given this medication, they'll still be in the 160s in spite of giving the rate control agent. So this is something I talk about a lot, like during shift. I don't think that we should aggressively focus on their heart rate when they come in. We should be looking for underlying conditions and focusing on treating those. And so what are some of the underlying conditions? I mean, there's stroke, PE, thyroid. We know all the major ones. The two ones I want you to focus on, though, CHF, which is about 28% in this paper, and sepsis. So between these two, you get 60% of the secondary causes of AFib. So those are the things we should look at and focus our treatments on instead of just giving the rate or rhythm control agent. All right, well, we're all about the guidelines. So what do the guidelines say? So looking at the 2014 AHA guidelines, and they report before initiating any antiarrhythmic, you should treat reversible causes. This is a class 1 evidence A. This is the highest thing they could say. They all agree we should be focusing on treating reversible causes. Okay, so that's secondary AFib. The rest of this talk, I really want to talk about primary AFib. I really just wanted to talk about that topic because I thought it was very important. But for the rest of this, let's talk about primary AFib. So people like our patient, they came in, they have nothing else going on, no infection or anything. They drank a Red Bull, whatever. They just came into AFib or flutter, and they're presenting to you. Primary AFib. So what's an important thing to consider for these patients? Well, how how the concerning thing that happens when you have AFib is your heart starts fibrillating. And then you have abnormal mechanics and beating in your heart. And when you have this, you can have turbulent flow that could cause a clot to form, most typically in the left atrium. Now you live with this clot, and let's say one day you cardiovert back to normal sinus. So all of a sudden your heart starts beating normal. And this could be just you cardiovert on your own, or you go to the cardiologist or whatever and they cardiovert you. Well, with this new concentric squeeze, you could dislodge this clot and it could travel and cause the feared complication, which is the stroke, thromboembolic stroke. So what are some things that could cause you guys to be at risk for stroke? Anyone can shout some stuff out? Hypertension, diabetes, age, smoking, AFib. Is there any maybe scoring system that could kind of tell us all this stuff so I don't have to memorize it? CHADS 2, CHADS VAST. Yeah, there's a few out there, but yeah, those are the main ones. So actually, let's look at the guidelines, what they suggest. This is the AHA. And I even went further. I looked at the Canadian Cardiovascular and the European Society for Cardiology, and they are all in agreement with the highest level recommendation that you should be evaluating with some sort of scoring system. They all kind of use this CHADS 2 or CHADS VAST as they're recommended to assess for stroke risk. I want to pause here for a second, really think about what this means. So for the rest of this talk, we're going to be talking about different treatments, rate, rhythm, all this stuff. But I want to say that assessing for stroke risk is separate than all of that. You should be assessing for stroke risk in your AFib flutter patients regardless of how long they've been in AFib. Less than 48 hours, over 48 hours, 3 weeks, 2 months, whatever. Doesn't matter, you still assess them for stroke risk. Regardless of treatment choice, I give them rate control, rhythm control, treat underlying, all those. It doesn't matter, you still assess them for stroke risk. And lastly, treatment success. Okay? Let's say you cardiovert them to now normal sinus rhythm. You still have to assess them for stroke risk, and if they are high stroke risk, then you have to start them on anticoagulation. Because as you know, even if you can cardiovert somebody back to normal sinus rhythm on the EKG monitor, that just means that electrically they're in normal sinus rhythm. The heart may still be fibrillating for a little bit of time. There could be a delay, and the heart is still fibrillating for some amount of time, even after you cardiovert them back to normal sinus rhythm. So they're still at stroke risk after cardioversion. So if they have a high stroke risk, you should start them on anticoagulation. Okay? The rest of this talk, I'm not really going to talk about anticoagulation anymore, but just know that you should be assessing them regardless. I'm going to be spending time to answer questions at the end. I know we started late, and we have Dr. Scott coming in after, and I want to make sure to write on time.
We are in no rush to anticoagulate anybody with AFib. There's stroke risk even if you have a high stroke risk. You're talking about 3% a year. Nobody needs heparin or Lovenox for their AFib. This is outpatient management for long-term stroke prevention. This is not emergent or urgent stroke prevention in the emergency department. That's all I want to say about it.
It's still, they need to be assessed, and if they are high risk, need to be started, whether it's by us, by somebody. I just want to make sure that we don't forget about their stroke risk. And we're going to talk about this later because these patients relapse and stuff. So that's why I wanted to focus on it briefly. All right, let's change gears here. Like I said, we're going to move on from anticoagulation, and let's talk about another important factor, which is time of AFib. Okay, so the amount of time you're in AFib is important, and that's why we ask them how long they've had the symptoms. And this number, less than 48 hours, has been coming around. And where did this come from? Well, it came from here in this paper where they looked at people who were cardioverted at different lengths of time, and they quoted that within 48 hours, there was a thromboembolic risk of 0.8%. Now, for some reason, us physicians are weird. We like accepting risk of less than 1% of anything. You know, if you come in, I will be happy if you're at risk of heart attack or stroke or aortic dissection is less than 1%. For some reason, doctors like 1%. They don't like more than 1% risk. So here, this paper quoted in 48 hours, 0.8%. Wonderful. Less than 1%, we're all happy. That's the magic number. We'll do less than 48 hours. So what does that mean? So someone comes in 48 hours. If it's over, they've had the symptoms for over 48 hours. Or let's say they have no idea how long they've had the symptoms. So you gotta assume it's over 48 hours. What do? Well, you evaluate for their clot risk. So you could either reduce that risk by giving them Coumadin for 3 to 4 weeks, or some sort of other novel anticoagulation. And then they can go to the cardiologist's office and they could Cardiovert them there or something. Or you could do a TEE and actually look at the left atria and see if there's a clot. So those are the things you would do if they're over 48 hours. It gets a little bit trickier when they're under 48 hours. So let's say they come in, acute onset of symptoms. What do you do first? Well, when you ask the medical students, what do you do for everything? You do ABCs. Okay. If they're unstable, that's easy. You just zap them. It doesn't matter how long they've had the symptoms. But here's the tricky thing. If they come in and they're under 48 hours of primary AFib, nothing else is causing it, and they're stable, then what do? So this is what the rest of this talk is going to be about. So let's move on to cardioversion, and I want to kind of discuss this as a possible option for this patient. So there's two types of cardioversion. There's chemical, and that's when you use like an antiarrhythmic drug, and then there's electrical. So let's begin with antiarrhythmics. Just a brief review. We have our different classes. We have our sodium channel blockers, our beta blockers. This is the class 2. Class 3 is our potassium channel blockers, and then class 4 is our calcium channel blockers. There's 2 drugs I just wanted to focus on today. There's many antiarrhythmics, as you know, but 2 drugs that have been used here in atrial fib flutter. First one is amiodarone. So this is actually a mixed class. It's got its sodium channel blocker, but it's also an AV nodal blocker. So it affects the calcium channels and the beta channels. It blocks them too. Now, as you guys know, there is a slew of adverse events that occur from amiodarone. Anything from minor things like photosensitivity, corneal deposits and stuff, to major side effects, such as both hyper and hypothyroidism. You can get pulmonary fibrosis and even liver damage. So a lot of stuff from generally long-term amiodarone use. Now, does it work? This is actually a pretty good study, controlled trial, amiodarone versus placebo. Does it work? Which one is better? And the outcome? Well, they showed that at 1 to 2 hours, there was no difference between giving someone amiodarone and giving them placebo. The difference didn't start until 6 to 8 hours and then went all the way to 24 hours. So you started to see a benefit of amiodarone over placebo at like 6 to 8, but it continued to go up to 24. What does this mean? I think that amiodarone for this patient is not a good ED medication. Because what's a good ED medication? Something that I give and within the hour I see an effect. ED docs don't like to give something and hope that tomorrow it'll start working. I mean, that might be something that, okay, I'll admit the patient and then cardiology will do whatever and discharge them on amiodarone. But I don't think this is the best ideal ED drug, and it has a bunch of side effects. So I kind of want to introduce another drug that I don't think a lot of people are using yet, but I want people to start using, and it's ibutilide. So this is a class 3, so it's a potassium channel blocker. And as you guys remember, you need potassium to repolarize your cell during the action potential to bring it back down. And so by blocking potassium, you will prolong the repolarization phase of your action potential. How do you give it? There's lots of different ways people have quoted giving it, but I think the most commonly used would be a rapid infusion. And so they say the dose is like 0.01 to 0.03. That's for the peds. By the time you reach like 40 kilograms in the adults, you're just talking about 1 milligram. So for most of you guys, just memorize 1 milligram. Rapid push, you push it over 10 minutes. And generally that'll do it. Just one time, rapid push, 1 milligram. If you need to, if that doesn't do it, you can give up to a second time. You just gotta wait 10, 15, 20 minutes or whatever, and then you could give it again. So you can go up to 2 rapid infusions. What's this major adverse event? Well, as you know, if you prolong the repolarization phase by blocking potassium channel blockers, then you'll get a prolonged QTC. And so what might a major side effect be if you prolong the QTC? Torsades. You could get a polymorphic VTAC, such as torsades. So that would be the feared complication for this medication. Does it work? There's lately been a lot of studies looking at safety for ibutilide, and yes, it does work. It's got a high success rate of up to 50 to 70%. Now what about the side effects? So the earlier studies I looked at showed like 4 to 5% risk of VTAC. However, all the recent ones, there was one done like this past year, and they were quoting 0.6. So it's between that range. And this is only for the major sustained VTAC. There were probably a lot of minor, you come with like a brief episode of non-sustained VT that no one did anything for, or maybe not even noticed or whatever. We're talking about things that they actually had to intervene and they noticed. So in general, all these papers are kind of recommending, yeah, it's pretty safe. They recommend just cardiac monitoring for about 4 hours after giving ibutilide. 4 hours, that's the magic thing that ER docs love. We just observe someone for 4 hours. Basically to the end of your shift, and then you just discharge them if they didn't have any events or prolonging their QTC. So it's a pretty good medication. I would use it in caution people who have, or let's say they already have a prolonged QT before you give them the med, or they have abnormal electrolytes that put them at risk for a prolonged QT, or if they have some sort of ischemic or cardiac disease, they are probably not the best candidate for ibutilide. So what do the guidelines say? So looking at AHA, European, and Canadian guidelines, and they are all in agreement with pretty strong recommendation. Ibutilide can be used in non-ischemic or structural heart disease patients. And let's say you have a patient with WPW and AFib, well then yeah, this is for sure recommended. You actually, it'd be contraindicated to use amiodarone because amiodarone has AV nodal blockade. So this would be a better choice for that. All right, let's move on to electrical cardioversion. So briefly, how's it done? Well, for any kind of procedural sedation, it's a standard practice to recommend that they're fasting for 6 hours. I know there's a lot of evidence that might come out, maybe we don't need a fasting for 6 hours, but this is just what's reported, so I'm just letting you guys know. You want to give them good procedural sedation and analgesia. This is a painful procedure, shocking somebody, and you don't want to do it without them being pretty comfortable. So how does it work? So atrial flutter is just one large macro reentrant circuit in the right atrium. It is remarkably easy to cardiovert them out of atrial flutter. You really just need to break the circuit at any point. So even the lowest setting, 50 joules, is typically sufficient to cardiovert them. If you pound it on their chest, you can cardiovert them, but very minor. But atrial fib, it's a lot harder because it's just a bunch of ectopic micro reentrant tachycardias all over the atria. So in order to stop that, you kind of have to depolarize every myocyte in the atria, and so you have to have higher joules, sometimes up to the top setting, 200 biphasor. But electrical cardioversion, very high success rate. If you remember, the chemical cardioversions are generally 40, 50, maybe 60% successful, like I quoted before. But here, we're getting at almost 100% success with electrical cardioversion. Just gonna wake some of you guys up with a quick.
30-year-old construction worker called in for an update. His heart's beating mad fast. It just started. This never happened before. I don't feel right. Looks like stable SBT, doc. Should I do the adenosine? Gee willikers, sir. It looks like rapid A flutter. Give me the adenosine. Still rapid A flutter? Time for a Eli.
Emergency Medicine has this competition for their emergency medicine fellow or whatever. I submitted this video with the help of Adam, and I actually recommended you guys to apply, but I think the deadline's already gone, January 15th. So maybe next year. It's a really fun competition. I got runner-up, and then they gave me a free entrance to the conference, so it was pretty cool. All right. Woke you guys up, all right? Let's move on to our next learning point, and let's talk about the rate versus rhythm control controversy. So what's the issue? Well, here in the U.S., a majority of the ER physicians, when someone comes in rapid AFib, they just start them on rate control. That's standardly what is done here in the U.S. And that's not so in places like Europe and Canada. They're actually doing more rhythm control. So what's the big difference? What's the controversy? Well, it all kind of started in 2002. In 2002, two big trials came out. We have the AFFIRM, the RACE trial, and the AFCHF trial. These were huge trials, and they looked at rate versus rhythm control. They compared it head to head, and they showed that rate control was non-inferior to rhythm control and maybe trended toward lower morbidity and mortality, though those trends did not reach statistical significance. But all the US physicians were like, oh my God, why would I shock somebody when I could just admit them for rate control, which seems like a safer, maybe easier option, and they're saying it could be lower morbidity and mortality? Great. So everyone kind of was on board with it, and that's kind of where a lot of the biases against rhythm control came. But I want to say that I don't think that these trials should apply to what we're talking about today. Because if you actually look at these trials, the AFFIRM trial only used patients over 65 with high stroke risk. The RACE trial only applied to patients with persistent atrial flutter, Fib, who've already failed at a cardioversion, like in the clinic or so. And then the AFCHF, we're talking about severe CHF, really sick patients with severe atrial Fib. So these are basically really sick patients who basically had AFib flutter for like almost a year. We're not talking about the young person who's coming in with sudden atrial Fib, less than 48 hours, primary, nothing's underlying. These trials don't even apply. These are more important papers for the internist and the cardiologist to decide whether they should Cardiovert in the clinic in 3 weeks or a month or whatnot. This isn't for the ED. It's not really ED papers. So I don't really think we should be biased by these papers. So how do we decide whether a rhythm control strategy is worth it and we should do that over rate control? Well, let's do a pros and cons column. So let's start with the pros. In 1996, this author started describing the electrical remodeling that occurs in the heart when you're in AFib. So when your heart's in AFib, all the myocytes start to remodel to basically support more AFib. And the theory came up, this term, AFib begets AFib. I don't know if you've heard of that. Basically, the longer you're in AFib, the harder it is to go back to normal sinus rhythm because all your myocytes have remodeled to be AFib myocytes. And so if you want to shock them later or Cardiovert them later, it's just that much harder. And that's why you get these patients who've had AFib for years and there's nothing you can do. They're not going back to normal sinus rhythm. So really, it suggests that the sooner, if they're in AFib and we get them out of AFib immediately, that's better for them long-term and we prevent them from being in long-term AFib. Next, there's a lot of studies looking at sick patients in the ICU. In the ICU, they're all on monitors, cardiac monitors. And so you can note the second someone goes in AFib, someone gets admitted for sepsis or thyroid storm or whatnot, and then in the ICU, all of a sudden, on the monitor, they go into AFib. And so there's a lot of studies looking at, for those patients, if you Cardiovert them quickly back into normal sinus rhythm, they have a decreased mortality. So, maybe Cardioverting them back to AFib decreases mortality. But I'm going to actually cross this out. I don't really think it applies like the other trials we were talking about. These are for sick ICU patients who've got a lot of other stuff and probably secondary AFib. So in those patients, probably decreased mortality, but I don't think it really applies to our primary AFib stable less than 48-hour population who have come to the ER. And there's no definitive studies that has proven decreased mortality in those populations. So I'm going to take that off. But I think I could comfortably say that if someone comes in rapid AFib and nothing else, and we cardiovert them, we can discharge them and we'll have decreased admission rates and all the things that come with that. So decreased costs, less side effect, like adverse events that occur from being hospitalized and getting infections and all this stuff. So there is some benefits there. But the real question is it safe? Is a cardioversion rhythm control strategy safe compared to that of a rate control? So I looked at a lot of papers. I fell down the rabbit hole. Here's a bunch of retrospective papers and then a bunch of review papers. And let me just kind of summarize it to you here. So between 1999 and 2013, they published a lot of retrospective, a lot of reviews, and in general, they quoted an overall pretty high success rate. With adverse events, they basically said, most of them said 0 strokes at 30 days. Some of them went up to less than 1%. No one went above 1%. And they were quoting minor adverse events, pain at the site of being shocked or transient hypotension or something, minor stuff that didn't really change anything, up to 6%. So pretty safe. And then I saw a bunch of quotes for relapses where they get discharged and then 30 days later they're back in AFib of about 3 to 17%. These were not really good studies. They were all reviews and retrospective. Until 2013, this study came out. I think that this is the greatest support of rhythm control strategy we have this day. In Finland, it was about 8,000 cardioversions in over 3,000 patients. It's a huge study that I recommend you guys all look at. And what did they show in Finland? High success rate, 95.4, 88 of it being electrical. And what were there? 0.7% risk of stroke in 30 days. Wow, we're less than 1%. All the physicians were super happy. Okay, this might be the nail in the coffin, right? So I'm going to put here fairly safe, and I feel comfortable saying that. But obviously we have a cons column, so let's talk about that. So one of the best papers against it was actually not even a paper. It was this. It was a letter to the editor of the Finland people. And these guys basically looked at the data submitted by the Finland people and sub-analyzed it. And they said, if you sub-analyze your own data, look what it shows. So they broke that group, because the Finland people took all the patients who had cardioversion less than 48 hours and summed them together. But these guys, they broke it up into less than 12 hours and then 12 to 48 hours. So you broke down those patients into 2 different categories. And they saw, at less than 12 hours, it's even better, 0.3. That's better than 0.7. But then, if they looked at the 12 to 48 hours, it became 1.1. Oh my God, 1.1, over 1%. All the doctors are freaking out. I'm not willing to take over 1% risk. So I always thought we were safe up to 48 hours. Now they're saying maybe I should change to less than 12 hours. Watch, the next study will come and say only less than 6 hours is safe. So now it kind of shook things up. Like people were like unsure what was the safe range. Now, because that major paper that supported us was kind of like added some confusion. They also noticed something else when they really looked at the risk stratification for different patients. They noticed the high-risk features that cause more risk of stroke were female, CHF, and diabetes. So back to the cons list, I'm going to put 48-hour rule in quotation mark. Do we even know that 48 hours is the definitive amount of time, or should we reevaluate the amount of time that is safe to be in AFib before you cardiovert? Also, all those papers we kind of talked about is showing frequent relapses. So imagine that. You spend all your time, you shock somebody, all that pain, all that whatever, and then they're just going to go right back in AFib. It's like I'm wasting my time. So frequent relapses, it just makes things a little bit muddy the water. But the real question is, are they happy? Because, well, everything we're doing in medicine should be about the patient. And we should be doing stuff to make the patients happy, to make their lives better, to make them healthier, feel better. So there's actually some papers looking at this. 2006, after those 3 big trials, 2002, they had a slew of data, a bunch of numbers, and they were like, well, let's look at the quality of life of those patients in those trials. And basically, one of the major things they learned was, well, obviously, AFib patients' quality of life is pretty poor in general. I mean, they probably have other things going on with age and other medical conditions. So in general, AFib patient quality of life is pretty poor. But they did notice that a rhythm control strategy did not improve their quality of life, and maybe was even worse. You know, maybe the patients didn't like to be zapped, and it hurt, and so they were a little bit more upset, and their life wasn't that much better than the rate control people. Okay, so that's a lot of old data, but here, 2015, this is a big study where they prospectively looked, and they followed people who were cardioverted in the ER, and then 30 days later, they met up with them, and they're like, hey, how's your quality of life compared to before you went to the hospital? You know, you had AFib, you were feeling a certain way, we shocked you, 30 days later, how are you feeling? And they said there was no improvement in their quality of life in 30 days. I'm just saying, we're a rhythm control strategy. Our treatment did not change their life or improve anything, so why are we doing it? So this is the rhythm control pros versus cons. Now, there was a couple other points I wanted to add to the chart, but then as I started looking at data, I wasn't really convinced that I could sufficiently say this to you with confidence. So there's some other future considerations that we should look into more. The first one I had thought of was, well, if I cardiovert them back into normal sinus rhythm, maybe they don't need anticoagulation, and I save them from all the issues of anticoagulation, which is bleeding risks, cost of the medication, having to get frequently checked, all that stuff. But I don't know if we're really preventing these patients from needing long-term anticoagulation because, like I said, they frequently relapse, and oftentimes they have other stroke risks in general. So we're still going to be assessing them for stroke risks, and oftentimes these patients will be put in anticoagulation, regardless of whether we did rhythm or rate control strategy. So I don't think yet I could say that we're preventing them from long-term anticoagulation based on our choice of cardioversion. There's no really definitive papers that say that. The next thing is, well, I know that AFib patients have a yearly stroke risk that's higher than normal sinus rhythm patients. So maybe if I cardiovert them back into normal sinus, I will decrease their yearly stroke risk. But I also, again, I don't think I can definitively say that because first off, like they said, they frequently relapse, but also all the papers that say AFib patients have a higher stroke risk than normal sinus are comparing it to people who've never had AFib, you know, normal sinus rhythm, people who've never had AFib. But I don't think you could say that somebody in AFib who gets converted back into normal sinus goes back to that original no-risk person, you know. They don't have papers looking at previously cardioverted normal sinus rhythm patients compared to AFib patients. So I can't definitively say they have decreased stroke risk either. So these are future things that we should look at to see if can I add these to the pro column or not really. All right, finally, let's talk about the Ottawa Aggressive Protocol. So this is Ottawa, capital city of Canada, home of Parliament Hill, the Rideau Canal, and basically a slew of rules, ankle rules, knee rules, subarachnoid rules, all this stuff. And they're all kind of done by this Dr. Ian Steele. This guy seems like a powerhouse of studies. Like everything I was reading in AFib, he had his name written somewhere. They're publishing like mad over in Ottawa. It's amazing. So he was the brainchild of the Ottawa Aggressive Protocol. And this initial paper, 2010, was basically a retrospective look This is what we're doing here in Ottawa. Everyone pay attention. We're doing this cool protocol. We're all on board with it, and it's pretty cool. So let's look at what their protocol is. So someone comes in, AFib primary, less than 48 hours. So what do? You know ABCs, of course. And if they're unstable, we know what to do. And then after they got evaluated, all of them got procainamide. In Canada, they like procainamide. And they had 58.3% conversion back to normal sinus rhythm with the procainamide. If that didn't work, all of them got shocked. The rest of them, the other half of the patients got shocked. And there you got another 91% of those got successfully cardioverted. Then, right after they were shocked, after they were observed for not long, like an hour or so, they got discharged. They were able to discharge 96.8% of their patients. They only admitted 3.2% of their primary AFib patients. That's crazy. Way, way better than what we're doing here. We're admitting way more. And here's what they resulted. No strokes. Now, this initial paper only looked for 7 days. 7 days out. And they saw adverse events, minor stuff, nothing too major. Okay, this isn't too crazy of a paper. I think it was like 600 patients. It was retrospective. They only followed for 7 days. All right, I'm not going to change my policy in my hospital based on this paper. However, this past year, Dr. Steele added again, 2017, basically almost like a prospective validation. He basically then, after that initial paper, for the next few years, followed prospectively these patients up to 30 days this time to see if he could confirm what they initially had quoted in that first paper. And what did they show in this paper? Success rate 80%. So not as high as that first paper, but still pretty good. Adverse events. They saw 1 stroke, and so that's a 0.1% stroke risk. That's pretty low. No deaths. Adverse events, a little bit higher, 10.5, but still they were all minor, nothing too crazy. A couple other things I wanted to know. They did look at who were the high-risk patients, got the stroke or the adverse events, and they saw obviously the longer time you had AFib, closer to 48 hours versus 12 hours. So we kind of already suspected that. If you had a history of stroke, okay, sure. And if you had evidence of CHF. The other studies also say, CHF is a high-risk feature. So they kind of noted that. But they also learned one more thing that I think is worth noting. So while Steele was basically monitoring all his physicians in Ottawa Hospital for those few years, he noticed that pretty much half of them forgot to assess for stroke risk. They just didn't, and for the patients who were high risk for strokes, they didn't consider anticoagulation or start them on the process. So 30 days out, these patients were not on anticoagulation. High risk patients who should have been, about half. Now, we only had 1 stroke in 30 days, so okay, they were lucky, nothing crazy happened, but he still said, this autoaggressive protocol maybe made all our physicians kind of forget that they are still at risk for stroke, and he noted in this paper, and he's like, okay guys, we like this method, it's still pretty successful, but we should still consider stroke. All right, this is the big conclusion, okay? What do the guidelines say? Should we be using a rhythm control strategy for these less than 48-hour patients? I looked at the AHA, I looked at the Canadians, the European guidelines, and what do they say? The Canadians, Europeans, pretty strong recommendation in less than 48 hours. One of them says you may, the other one used the word you can, whatever, may, can, Cardioversion, they allow it, they kind of give support of it with good recommendation. Cool. What do the Americans say? They choose not to comment. They, unfortunately, in their guidelines, I searched through it, they didn't really say you may use cardioversion, you should use cardioversion, you can use. They didn't really touch on that. All they kind of said was, if you choose a cardioversion strategy, then you should do this, that, and the other. But none of them said you may or can use it. So the AHA, the Americans kind of bowed out of the discussion. But in Europe and in Canada, they are doing it and their guidelines recommend it. So back to our case. You know, we had a patient. If you calculate this patient's CHA2DS2-VASc score, he had high blood pressure, was the only thing, but everything else was negative. So I'll give him 1 point, a CHA2DS2-VASc of 1. What ended up actually happening with this patient was we got cardiology to see him, and they were intrigued, so they did an EP study on this Flutter. They saw a typical counterclockwise atrial flutter, and they ablated it. And the patient got discharged in normal sinus rhythm. So, success story, but you know, the patient got a hefty admission and procedure that maybe they didn't need. I mean, could this patient have just been cardioverted in the ER with pretty low joules for a flutter? And then CHA2DS2-VASc of 1, maybe we could consider starting them on aspirin or something and discharging them with cardiology follow-up. Maybe we could have done that. Just something to consider. So, in summary, we should always be searching for secondary causes. Is there anything else underlying here? Focus our search on that and treating on that before we choose rate or rhythm or anything like that. And also remember to evaluate for stroke risk. We talked about cardioversion, electrical cardioversion. We learned how to do it, and it's pretty safe. And then maybe I taught you guys about a new medication, Ibutyl, which you guys should consider if there's no heart or structural or ischemic heart disease. We went over the rate and rhythm controls controversy. I kind of discussed, I think there is rhythm control pros that has proven it to be safe. There's still some cons. I mean, whether it's worth it if people's quality of life is changed. I think this is where shared decision making comes in. You know, you sit with the patient, you kind of give them the options. Maybe they're like, no, I don't want to be shocked. Or, no way, I want to be started on anticoagulation or Coumadin. I know a friend who died from a brain bleed. I will never take it. Yeah, I want to take the shot, maybe Cardiovert me, and I'll go from there. Or, let's say they're like, you know what, I have a private cardiologist. How about I go home and go to the clinic in the morning? It'll still be less than 48 hours. Let's say they came in within 24 hours. Okay, I'll go home. It'll still be less than 48 hours tomorrow. I'll fast for 6 hours or whatever and let my cardiologist decide. So these are all things you can kind of sit and discuss with the patient and kind of make a shared decision making. But I think it is something we can do, and we should consider doing more rhythm control. And lastly, I thought the Ottawa aggressive protocol is pretty nice, especially with this new study that came out this past year that kind of supported it. But remember the lessons learned from that study. You know, a lot of them forgot to do stroke risk, so I think that's an important thing that you guys should all consider. And that's it for me. Thank you guys. We are right at 11, so I can take maybe a few questions, and then Dr. Scott will come up. Yes?
So a quick question about the Ottawa aggressive rules is that they should still be doing, so if they Cardiovert, they should still be doing CHA2DS2-VASc for, like that's the part that's confusing me. You said that they didn't assess for stroke.
So here's the thing. If there's electrical mechanical delay when someone goes from AFib to normal sinus rhythm. So what does that mean? So my heart's fibrillating in AFib. If I shock it back into normal sinus rhythm, the EKG monitor will show normal sinus. So the electrical current through the heart will be normal sinus. However, the muscles of the heart take time to go from this to this. So there could be a couple days or so where they're still fibrillating. And that means they're still at risk for clots. So because of this delay, we could still consider them that they're in AFib until the cardiologist sees them and stuff and confirms their normal sinus and stuff. So we may consider if they're high risk doing anticoagulation, then they could stop that in the clinic because of this electrical and mechanical delay. Does that make sense? Eden?
Yeah, so I think, so the cardiovascular literature refers to that as atrial stunning, and the main risk is if you try to Cardiovert them, and they've been in AFib for greater than like 24 to 48 hours. So that's why it's very important to get that good history from them. If you Cardiovert them with like less than 48 or 24 hours, then there's essentially
Yeah, so I did see a lot of studies talking about mag, and I didn't really want to talk about it, but there is suggestion that magnesium pre-treatment could reduce the risk. Basically, we give mag to stabilize. So how it works in preventing torsades is induced by an after depolarization that occurs, and mag has been shown to maybe stabilize and prevent that after depolarization. But I don't think the studies are so definitive that mag works to fully support it in the guidelines, but it is suggested by some of the new literature. So it's something to consider. Yeah, definitely mag pre-treatment. Yeah?
So I feel like the minority of patients that I see with AFib with RVR, new onset AFib with RVR, I feel like the majority have had either established AFib or are often as an off-metoprolol or whatever link they're on. Do you, based on what you read, is the Ottawa protocol, the Ottawa breast protocol still something used in these chronic AFibers, or is it really?
No, Ottawa is less than 48-hour patients.
Well, but that means if they have pre-existing AFib or known AFib. I feel like a lot of patients most patients I see have pre-existing AFib. It's rare that I get somebody with brand new first time AFib.
I don't think they apply to those patients. I think they're excluded.
I think that's the, like, kind of the really important thing. I think probably cardioverting patients is the best thing for the patient in terms of their experience, because they get cardioverted and they go home. But it's very hard to find that patient. I found like 1 in 5 years who this applies to. I think that's the problem. Most of our patients come with AFib, they have a history of AFib, or they didn't even know they were an AFib, so you have no idea the onset was 48 hours ago or 4 weeks ago. And I think that's the hard part of determining who's been less than 48 hours and who's not.
So yeah, I mean, that's the real question. I mean, they got a good amount of patients, like 600 patients in a couple of years over in Ottawa. So it is seen in different places, maybe not so much here. But I also think as we move forward, this will be a more important topic. Because guess what? I know my heart rate at all times because of this. And we're all getting this way. So I think pretty soon we're all going to be on some sort of cardiac monitor, and this will tell me the second my heart rate goes in above 100. And so maybe in the future we'll be able to more definitively tell when these things are going. So just something to think about for future considerations. Dr. D'Souza?
Yeah, and I think so the guidelines don't specifically, you said this, don't specifically address the risk of stroke in this subset of patients. And you can see from all these studies that the strokes were basically almost zero in all of these studies, probably thousands of patients. So I think that's part of the discussion you should have with your patient as well, is give them the results of these studies, pull them and say, like, this is almost none of these patients have strokes. So maybe your threshold for anticoagulation using the CHADS should be different in these patients. Or maybe you should say, here's the risk, you don't need anticoagulation at all. And that becomes a benefit of cardioversion as well. So the guidelines I don't think they specifically address these patients.
They still say for high risk CHADS VAS2, they should be on anticoagulation. They don't really say, if they're back in normal sinus rhythm, forget about their CHADS VAS. They don't yet say that.
Well, and part of the reason I asked the question about pre-existing AFib is I've had the misfortune in my limited clinical experience of already seeing 2 strokes from cardioversion. But they were both people who had pre-existing AFib that came in another round of AFib and were cardioverted at that time. It wasn't their first episode.
They don't apply because, like we said, these patients may be going in and out of AFib flutter for months. And so they have months of time to create their clot. And so we're talking about the new onset primary AFib people that you're sure don't have a clot because of the time. If you're unsure how long they've been in and out of AFib, then they're in the unsure category or the over 48-hour category. All right, this is a big discussion. I know there's lots of questions, but I'm going to end it here. And Dr. D'Souza and I are actually going to creating a committee to maybe do some sort of protocol. But like if you guys want to get involved to talk more about it, you can kind of talk to us about it. But thank you for having me here today.
Okay, everyone, you can stretch your legs.